Good evening, everyone. We're going to get started. First, I'd like to thank everybody for attending tonight's Ahead of Cancer lecture series sponsored by the Allegheny Health Network's Cancer Institute. My name is Michelle Studnicki, and I'm one of the program coordinators for the Cancer Institute. There are a few housekeeping items we want to go over before we start. Number one, during the presentation, all participants can type into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture, if time allows. Number two, participants cannot speak during the conference, but again, we encourage feedback via the chat option. Tonight's lecture is being recorded. If you're interested in rewatching this lecture or any of our past lectures, please check out our AHN YouTube channel. The entire lecture series are posted under the Ahead of Cancer lecture series playlist. Lastly, if you'd like to schedule an appointment or have any questions regarding a potential concern, please feel free to call our Hope line at 412-578-4673. And we'll also repeat those numbers at the end. Our topic tonight is breathing easier, early detection, and innovative treatments for lung cancer. We are pleased to welcome Dr. Colonias and Dr. Weksler this evening, and I'd like to take a moment to introduce these remarkable individuals and showcase the impactful work they're doing right here at Allegheny Health Network. Dr. Tom Colonias was named the attending radiation oncologist at Allegheny General Hospital in 2001 after completing 4 years of residency training at Allegheny General Hospital. He is highly skilled in the use of stereotactic radiosurgery and intensity modulated radiation therapy and has a special interest in treating thoracic malignancies. Dr. Colonias holds numerous leadership positions, including clinical director of the Allegheny Health Network Radiation Oncology practice and vice chair of the AHN IRB. He also has a strong interest in clinical research, presenting at national and international meetings and publishing several manuscripts. A graduate of Northeastern Ohio University's College of Medicine in 1996, Dr. Colonias completed an internship at the Mercy Hospital of Pittsburgh and received an undergraduate degree from Duquesne University. Dr. Colonias is board certified by the American Board of Radiology, Radiation Oncology. He is a member of the American College of Radiation Oncology, the American College of Radiology, the American Medical Association, the Society for Therapeutic Radiology and Oncology, and the American Society of Clinical Oncology. Dr. Benny Weksler is a renowned minimally invasive thoracic and esophageal surgeon. He holds an MBA, an MD, an FACS, and an FACCP degrees. His research focuses on smoking cessation in surgical patients, novel esophageal cancer treatments, and lung cancer immunotherapies. Dr. Weksler received his medical degree from the Federal University of Rio de Janeiro, Brazil, and completed his general surgery at the New York Medical College program. He undertook a 2-year research fellowship at Memorial Sloan Kettering Cancer Center, followed by his surgical residency and a thoracic surgery fellowship within the New York Hospital Cornell Sloan Kettering program. He further specialized with a 1-year minimally invasive fellowship at the University of Pittsburgh Medical Center. Currently, Dr. Weksler is a professor of cardiothoracic surgery at Drexel University College of Medicine, holding the Edward M. Kent, MD, endowed professionalship of general thoracic surgery. He serves as the System Chief of Thoracic Surgery right here at Allegheny Health Network and Chief of the Division of Thoracic Surgery at Allegheny General Hospital. Dr. Weksler is an active member of numerous professional societies, including the American Association for Thoracic Surgery and the Society of Thoracic Surgeons. His clinical interests encompass esophageal cancer, lung cancer, chest wall diseases, minimally invasive and robotic surgery, and surgical endoscope. He has extensively published in all of these areas. Welcome, both Dr. Colonias and Dr. Weksler. I'm going to hand it over to Dr. Weksler now as we begin our lecture series. Thank you.
Thank you, Michelle. That was a long introduction, but thank you. I'm flattered. Uh, I'm very honored to be here and to speak on this great lecture series ahead of cancer. And we'll be talking about lung cancer. So let's see here. So lung cancer incidence and mortality, you can see that lung cancer is the third most common cancer, but it's the number one cancer killer in the United States, with 127,000 deaths in 2023, which is more than the next two or three cancers combined. So it's a significant problem. One in every four cancer deaths is from lung cancer, 25%. This is the incidence of both lung cancer and smoking, and they overlap. And there is no doubt that the 90% of lung cancers are caused by smoking. If we look at the incidence of lung cancer in Pennsylvania compared to the rest of the country, you can see that it appears to be a little lower, certainly as compared to West Virginia and Kentucky. But what this statistic misses is the fact that there is a significant difference in incidence of lung cancer between the eastern part of the state and the western part of the state. So here in Western Pennsylvania, where we are, our incidence is way closer to West Virginia than it is to the average US numbers. And like I mentioned before, there is no doubt that the risk of lung cancer is proportional to smoking. The more you smoke, the higher the risk of lung cancer. And you can see that although never smokers may have a few cases of lung cancer, it definitely does not compare to patients that have been smoking a pack a day for 30 to 60 years or more. And we can't speak of lung cancer without addressing the cost of cigarette smoking, and the costs are astronomical. There are almost 500,000 premature deaths each year because of tobacco smoking, and that's about one every five deaths. Smoking causes more death each year than all those combined: HIV, illegal drug use, alcohol use, motor vehicle injuries, and firearm-related incidents. I think we don't hear enough about that, but that's the reality. And the reason that people smoke is nicotine. After inhaling a cigarette is a great mechanism to deliver nicotine to people. You have euphoria without being stoned, and you have immediate reinforcement of the drug taking behavior as you take another inhale of the cigarette to your mouth. And despite the fact that many consider lung cancer and some of the other diseases caused by cigarette as a life choice, we forget that during the time that people today are having lung cancer, when they were growing up, those are the ads that they were looking at. Cigarettes promoting good teeth and your dentist recommending your smoking. As time went by in the early 70s, again, those are the people that are getting lung cancer now. Those were the ads that were allowed, showing young, healthy people having fun on the beach and smoking Newport. And never forget that us, taxpayer and US government, sent a whole generation of veterans. Today is Veteran Day, so it's interesting to talk about it. a pack of Marlboros with every K ration that they received every day. The other thing that people don't realize about cigarette smoking is that it's just as addictive as heroin or alcohol. And this graph shows the rate of relapse of smoking compared to heroin and alcohol abuse. And you can see that the lines overlap, meaning the chances that somebody addicted in heroin will stop using the drug and go back to it at a later time is the same as somebody who is smoking and stops smoking and eventually will go back to smoking. The risk is the same. For patients that have smoked many years, it's important to know that it's never too late to stop. And you can see effects of smoking cessation starting 20 minutes after you stop smoking. And those keep getting better as time goes by. Unfortunately, the risk of heart disease-related death and risk of lung cancer will take between 10 and 16 years to level at the risk of the general population that does not smoke. But it always helps to stop smoking. Any time is a good time. The good news for us who are fighting lung cancer is that the smoking prevalence in the United States have been dropping year after year, which is a reason that the number of lung cancer cases have been dropping as well. And that's a very good news. The least amount of smoking, the less lung cancer we are going to have. And there are reasons that lung cancer has a relatively poor prognosis. One, we diagnose patients too late, and you can see that almost half the patients are diagnosed at stage 4, which means metastasis, often not curable. And the treatment are not very good. You can see that 58% of patients with stage 1 are alive 5 years later, versus only 6% of patients with stage 4. So two-pronged issue. This started to change with this study which was published at the New England Journal of Medicine and made the first page of the New York Times, showing that CT scans will decrease death by lung cancer among smokers. And the CT scan screening will reduce lung cancer mortality by 20%. In case there are people out there thinking, well, 20% is not all that much. We sometimes fail to realize that this reduction is the same reduction that we have in mortality for breast cancer screening with mammograms and colon cancer screening with colonoscopies. It's the same 20%, so it's perfectly justifiable. CT scans for screening of lung cancer are covered by all insurance now, and they are recommended for patients who are 50 years old or older who had smoked at least 20 years a pack a day. So I would strongly encourage everybody who qualifies to get screened. Allegheny Health Network has a very large screening program. We discuss those cases every week, Dr. Colonias and I, in a multidisciplinary conference to try to find ways to help those patients. Switching gears a little bit, as we try to diagnose patients earlier with least invasive, we were actually the first in this area to have this device. It's the ion robotic bronchoscope. And this is really a skinny GPS that goes to those lung lesions and allow us to take biopsies. very advanced device. And here at Allegheny Health Network, we already have done over 1,000 cases with this with great success. And this is how this little tube works. It's very flexible and it can go all the way to the outside of the lung to do biopsies of small lung cancers so we can treat them earlier. And treatment, Dr. Colonias is going to talk a little bit about radiation, but the mainstay of treatment of early stage lung cancer is lung resection, meaning removal of the cancer. And it is interesting to me that Allegheny General Hospital was actually involved in the first curative resection for lung cancer. That was in 1933. This gentleman on the picture, Dr. Graham, did a lung resection, resected a cancer in a gynecologist who had lung cancer. And this gynecologist practiced at Allegheny General Hospital. Dr. Graham was a heavy smoker, just like the gynecologist, but that patient survived Dr. Graham by 30 years. Dr. Graham died way earlier than his patient because of actually lung cancer because of smoking. So just like Shakespeare said, you know, the way to go with lung cancer is out them spot, out I say. And that kind of brings us to the changes in surgery. And when I started practicing, not that long ago, but I guess long enough, what we did is we had to open the chest every time. And I hope nobody's going to faint with this, but this is an open chest with a retractor. The lung is showing up. This was very, very painful. And then we got this device here, the Da Vinci robot. You can see the 4 little arms, and I'll show a video for you guys in a few minutes, doing the same exact surgery through tiny, tiny incisions. And it brings a lot of advantages to patients, less pain, less narcotic use. Patients routinely now go home in 1 day versus 5 to 6 days before. There is earlier return to usual activities, quality of life is improved, and better tolerance of other treatment when they need it. Another big evolution for us was taking less lung and allowing us to do more surgery and save lung for patients. The traditional surgery for lung cancer was a lobectomy. You can see this is a lobectomy here. Hopefully you see my arrow. There are 3 lobes on the right side and 2 on the left side. But with better screening and with smaller cancer, we discovered that we can do smaller surgeries like segmentectomy or even a wedge resection, sparing a lot of lung. And we believe that that's improved quality. And to do this accurately, again, we're the only one in the region to have this. This is a very sophisticated 3-dimensional reconstruction of the lung that allow us to spot exactly where the nodule is. And you can see those things here are the nodules, and also the exact anatomy inside the lung. So we can remove the whole area with little risk and knowing exactly what we're doing. And this have really improved our ability to take care of patients with lung cancer, both improving their quality of life and also being able to remove cancer in patients that maybe a few years ago we wouldn't be able to do that because we would have had to remove too much lung. Now, this is where I started practicing, and the only reason I bring this slide is to show you how incredible the evolution in lung cancer has been since I started practicing. It's just unbelievable. When I started, just before that, you know, we were talking about 3 or 4 important things like, you know, the surgery, single agent chemotherapy, chemoradiation, and then platinum-based chemotherapy. And then since I started practicing, look at the explosion of different things that have happened. And I do want to bring a couple. And this is one that's most fascinating to many of us, which is the immunotherapy for lung cancer. Lung cancer cells are really sneaky, and they present our immune system with molecules that tell the immune system to basically die, and the cells die. And this drug, the immunotherapy drug, what it does, it prevents this from happening, kind of turbocharging our own immune system to fight the cancer. And this has really improved prognosis in many of our patients. The other thing is that treatment for lung cancer today is really in the realm of personal medicine. Each patient has a different strategy depending on the cancer that they have, and if that cancer has mutations that we can target. So a huge change from before, in which everybody got more or less the same. Just a few days ago, came the State of Lung Cancer by the American Lung Association, showing that survival rate climbed from 18.2% to 29%, 5-year survival. And I think this is amazing improvement, but it's also very humbling, telling us, we still have a lot of work to do, right? I mean, 70% of patients end up dying of lung cancer, and that's not good enough. If you look at other information, I know this is a little small, you can see that unfortunately, nationally, only 18% of patients at high risk are screened. So 82% of patients that could be screened and could perhaps have earlier procedures for lung cancer are not having it. If you look at state ranking new cases, Pennsylvania is kind of not too bad. This is the national average in red, and Pennsylvania is in green. But remember, there is a difference between the eastern side of the state and the western side of the states. Screening, also, we are doing better than national average, but not necessarily great. And finally, number of patients treated with surgery, which is a quality metrics for the American Lung Association. The red is national average, and this is Pennsylvania. So Pennsylvania ranks 12 out of the 49 states in the continental United States, with 22% of patients undergoing surgery. And survival rate also in Pennsylvania is not bad, but again, it's worth remembering that we have two different populations depending on the side of the states where you are. And this is just a little taste of what robotic surgery looked like to us. I control those instruments from outside, and what we're doing is we are taking the smaller piece of the lung. We're doing a segmentectomy, a small anatomical piece, and I just divided the main vessel to that lung, and now I'm going to divide the airway that's going to go to that small segment. But you can see how the motion is very, very precise. And those structures we're talking about, they're less than half an inch in their width, and we can dissect them very, very precisely. And then we can use the laser of the robot to demarcate exactly the area that we need to remove, sparing pretty much all the rest of the lung and hopefully curing this patient of his lung cancer. I think I'll stop here. Thank you all for taking the time to be with us today. And thank you, Michelle, for inviting me.
Okay, I think we're going to turn over to the next speaker, right, Michelle? We're going to turn over to our next speaker.
Correct. Up next, we have Dr. Colonias.
Hi there, everybody. Just getting my slides up. And hopefully everybody can hear me and see my slides. Again, thank you. Thanks for inviting me on this talk. And hopefully I won't bore you too much following Dr. Weksler's great presentation. So my name is Tom Colonias. I'm a radiation oncologist. I've been at AGH for quite some time, and AHN and working with Dr. Weksler over the years. I have no disclosures or conflicts. So, my talk's going to focus a little bit more on the radiation aspect of treatment. And, but before I get into the nitty gritty with radiation, I just kind of wanted to go over some background information regarding how can we improve outcomes and quality of life when it comes to lung cancer. Well, early detection and risk reduction, as Dr. Weksler said earlier, are keys to that. And then obviously improving treatments, and that's surgery, that's medical oncology with medicines such as immunotherapy and targeted therapies, and radiation, and that's what I'll focus primarily on. So just a couple lung statistics that Dr. Weksler reviewed already. Lung cancer, over 200,000 new cases in the US. A lot of these patients unfortunately die of the lung cancer. Excluding skin cancers, it's the second most common cancer in both men and women, but it's the leading cause of cancer death in both men and women in the US. So we're making progress, but obviously we have a ways to go. So how can we improve outcomes? One way is to reduce reduce and prevent lung cancer in general. Tobacco use is still the biggest risk factor. 80 to 90% of cases are linked to smoking. So obviously smoking cessation is valuable. Educating young people to prevent them from starting to smoke is also very important. Other things that are important: secondhand smoke exposure, radon. Radon is a naturally occurring gas, and it's colorless, odorless. It is radioactive, and it's been linked to lung cancers. We have a higher prevalence of it in this region, just based on geography. Other things that contribute, just pollution in general, that's air pollution and particle pollution, occupational exposures like asbestos, radiation exposure. Even though we use radiation to treat, it can cause cancer also. So looking at the incidence of lung cancer and when we catch it, if we can catch it earlier, the outcomes are better. So just looking at this slide, when about 25 to 30% of cases are caught early, about 20 to 25% cases are caught with lymph node involvement, but still confined to the thorax. And the majority of cases are still caught whenever the cancer has spread outside of the thorax or chest. When we look at outcomes, if we catch it earlier, the cure rates are a lot higher. So if we catch it early, the cure rates, 5-year survival is 60, 70%. And as the cancer gets more advanced, the survival rates go down. So the key is to catch things early. And as Dr. Weksler stated before, annual screening of high-risk patients has definitely improved the outcome and decreased cancer death rates by 20%. It's still underutilized. Less than 20% of high-risk patients nationally are being screened. So we have a job that's still to do to try to screen more patients and catch things earlier. In general, it's patients that are 50 to 80 years of age. They have a 20-pack year history of smoking. So that means they smoked a pack of cigarettes for at least 20 years or smoked 2 packs of cigarettes for 10 years. And they can be patients that have quit smoking, but they have to quit within the last 15 years. We definitely have a very active screening program at AHN, it's growing and rightfully so. We've caught a lot of cancers there. So I would encourage, if there's any questions about screening, that is something worthwhile. So focusing a little bit more on treatments, how can we improve the outcomes and quality of life in lung cancer patients? Well, Dr. Weksler focused on thoracic surgery, so I will not, but in general, better surgical techniques, use of the robot, better post-operative care, better pain control have definitely improved the outcomes. And with the better techniques, we can do lesser surgeries, less recovery time, etc. From a medical standpoint, medical oncology standpoint, there has been an explosion of new treatments that were not in existence even 10 to 15 years ago, primarily immunotherapy and targeted therapies. So what the standard now is, we do biopsies of these tumors and we run analyses to see, are there mutations that we can target? So this has definitely helped improve the outcomes tremendously. And a lot of these treatments are associated with less side effects. So it's a win-win. And this area is exploding tremendously. The other thing is, we're better at supporting patients that are going through treatments, whether it's aggressive chemotherapy regimens or whether it's immunotherapy or targeted therapies. We're just better at managing these patients and getting them through. So all these have contributed to better outcomes. So as far as radiation oncology, what can I say about how this has impacted the improvements in outcomes? Well, it's all based on technology. So over the years, we've gotten a lot better at defining where tumors are and delivering the radiation very precisely to those targets and trying to minimize radiation dose to the normal tissues. The lung cancers can sit next to the heart, they can sit next to the esophagus or food pipe. Well, if we give full dose to that tumor, we can, theoretically kill the tumor, but we can cause major problems with the patient swallowing because we irritate or scar off their food pipe. So, and treating and curing cancer is one thing, but we also got to focus on quality of life. And these techniques have allowed us to really get a lot better at that. So over the years, techniques that we've been using: 3D conformal, intensity modulated radiation, image-guided radiation. Image-guided radiation basically is doing a scan or a CAT scan before you deliver the radiation in order to make sure that you're precisely treating the tumor. Stereotactic radiotherapy, and sometimes it's called stereotactic ablative radiotherapy or SABR, and gamma knife. Gamma knife is basically SBRT to the brain. And over the years, we've obviously gotten better at supporting these patients and getting them through treatments. So kind of going over the evolution of external radiation techniques. In the 70s and 80s, we used to treat with two-dimensional conventional radiation. So basically, we would treat a patient with a beam coming in from the front of the chest and the back of the chest. And I have slides, pictures that kind of show this. Over the years, we started using CAT scans to help in treatment planning, and that's called 3D conformal. That allowed us to reconstruct tumors in patients on the computer, allowed us to monitor dose to the tumors a lot better, and also monitor radiation dose to the normal tissues to make sure we're not giving too much dose to the normal lung or the heart, etc. So 3D conformal really allowed us to be more accurate in delivering the radiation and not missing the tumor, but also with less side effects. And then in the 90s and on, IMRT came into play. IMRT is basically using 3D conformal basically on steroids. So it's allowing us to come in from different beam angles throughout the patient in order to intersect on the tumor and give precise high doses with very rapid dose fall off. So again, not missing the tumor and less dose of the normal tissues and less side effects. When we do the radiation, it's a multi-step process that we go through. The first step is a simulation. When we do the simulation, we have the patient lay in a certain position and we make a mold so that they can lay in this mold every day for treatment. And then we do a special CAT scan in that position, and we put marks on their skin and they go home. At that point, we do a lot of offline treatment planning where we reconstruct the patient's anatomy on the computer. We define the tumor and we define all the normal tissues. And with beams of radiation, we target the tumor, and we know what doses of radiation we want to give the tumor, and we know what doses of radiation the normal tissues can tolerate. So we kind of struggle between giving the most radiation to the tumor without putting the patient at high risk of side effects by monitoring dose of the normal tissues. And then once we're ready to treat the patient, we bring the patient back and we set them up in the machine room and we deliver the radiation. The number of treatments really depends on what site we're treating. Are we giving it with chemotherapy or not? So there's a lot of factors involved, and I'll go over that over the next few slides. So this is an example of an old technique of radiation where conventional radiation, which we rarely do anymore. So this is a CAT scan of a patient, and it's a slice through the patient. This is the patient's chest, and this is the patient's back, and the black is the lung, and this is the right lung, and this is the left lung. The heart sits right here in the center of the chest. And this is actually a patient that has an esophageal cancer. And that red area is the tumor in question. So with this technique of radiation, basically everything that's within this blue line is getting full dose of radiation. So you can see the tumor's getting treatment, but all this tissue in front of it, including the heart, is getting full dose. So this is an older technique that we rarely use anymore. 3D conformal allowed us to be more conformal with the dose. So again, same patient, same CAT scan, same tumors right here. And you can see that the blue lines this time are a little bit more conformal. They're not covering, they're less off the heart than before, a little bit off the lung, but still not great from a standpoint of still treating a lot of the heart. And you can see on the side view that a lot of the tissues are still getting a lot of good dose of radiation. So when we go to the IMRT technique, which is this slide here, again, the patient's chest, the patient's back, the tumors right here, you can see that these colors are a lot smaller, meaning the dose of radiation is more confined to where the tumor is and not in the area where the heart is or where the normal lung is. And on this side view, you can see how the dose of radiation dips in and avoids the heart, which sits right here. So this is an example of how technology has allowed us to deliver the dose of radiation that we need to the tumor, but try to do it in a way where it's more conformal, meaning closer to the tumor and away from the normal tissues. So this is the slide this is just basically all three together. Again, this is conventional treatment with most of the heart getting all the dose, a lot of the lung getting dose. With 3D conformal, less of the heart is getting dose, less of the lung is getting dose. And with IMRT, it's even more conformal. Most of the left ventricle, which sits right here, is getting minimal, if any, radiation, and a lot of the normal lung is being spared also. So when we're looking at these, we may have similar cure rates because we're treating the tumor, but this patient would significantly have a better outcome from a quality of life standpoint, less cardiac issues down the road, less scar tissue in the lung down the road, which can impact his quality and it likely his survival. So the next few slides, I have a couple more examples of just some plans that I've done on a few patients over the last few years. This is a patient that had a lung cancer involving the right lung with some lung collapse and kind of growing a little bit into the center of the chest that we call the mediastinum. So the tumor is this area here. Again, the orient, this is the chest, that's the chest bone, and this is the back, and we're slicing the patient through axials. So this is the right lung is black, the left lung is black here. The tumor is this area here. So these colored lines indicate doses of radiation. So the yellow line is the prescribed line or the dose that I want to give to the tumor. So that's 4,500 units of radiation. So everything within this area is getting 4,500 units or the full dose. But you can see that the blue line indicates 2,200 units of radiation. So within only about a centimeter or so, the dose goes from full dose to probably a third of the dose. And that means that less dose is going to normal tissues. So you can notice that the left lung is being spared almost totally from radiation, which is a big deal. When we're looking at a view straight on, you can see the tumor being covered by the yellow, but you can see that these colored lines signified radiation dose fall off dramatically. So the left lung, again, is getting limited, if any, radiation. This is a case where a patient had very advanced lung cancer. The cancer involved the right lung, and it's this area here that's kind of adjacent to the ribs. And this patient also had involvement of lymph nodes. So these are the lymph nodes here. The issue with this patient is the lymph nodes involved the left lung also. So it's quite a big field for radiation. And undoubtedly, maybe 15 years ago, 10 years ago, I would have likely said that I probably cannot treat this patient safely without causing a lot of problems to his normal lung, resulting in breathing problems from scar tissue from the radiation. But with these advanced techniques, we can definitely treat this patient, and we've done numerous patients like this over the years. So again, to orient, this is an axial CT. This is the front of the patient. This is the back of the patient. Again, right lung is in black and the tumor is in gray. And the yellow indicates full dose of radiation. So everything inside of that is getting 6,000 units. Now, this patient was also getting chemo because it was advanced disease. So everything inside of this is getting full dose. And you can see that this orange kind of line here indicates half the dose. So that's 3,000 units of radiation. So you can see that within a very short distance, the dose goes from full dose to 50%. So it's a very rapid dose fall off. Less dose of the normal tissues mean less potential for side effects. And then this is a head-on view, and you can see that basically the dose of radiation covered from the right lung into the left lung, but the dose fell off dramatically after that. And then one other case to kind of review. This is a case, again, an advanced patient, and I want to focus on this part of the slide. This is a head view. This is another case where years ago, I likely would not have been able to treat the patient. The patient had a bulky right upper lung cancer with lymph node involvement, but he also had a lymph node under the collarbone on the left side. And again, the yellow indicates the full dose of radiation, and we were able to safely treat this patient and avoid the normal tissues. And this patient actually did very well. So the next part of my talk, to close with, I want to talk a little bit about stereotactic body radiotherapy. This is a highly conformal technique of radiation, allowing us to deliver high dose of radiation to a very small area. It's also called SABR. We usually do it in 1 to 5 treatments. And basically, it's an ablative dose. We give the full dose in about 1 to 2 weeks. And because it's so precise, we can do it in 1 to 2 weeks, not over the standard 5 to 6 weeks that we used to do it in the past. Example, a typical patient that we treat, that we use SBRT on, this is a patient that had a prior pneumonectomy. So this is where the left lung should be, but this patient had a lung cancer and had a removal of the total left lung years ago. And we were following her with scans, and then she developed this little nodule here in the right lung. Again, this is the right lung, should be black, and then you see this little gray thing here. We did a PET scan and it had activity. We biopsied it and it came back that it was a new lung cancer. So she was seen by a thoracic surgeon such as Dr. Weksler, who, based on her age and her prior surgery, said, we don't think she's fit enough for surgery. So instead, we proceeded with SBRT. So this is basically the radiation plan of using the SBRT. And again, these colored lines indicate doses of radiation. This area here is getting full dose, but within a centimeter or so, the dose of radiation is negligible, allowing us to spare the normal lung because she only has 1 intact lung remaining. This is another view of that, and this is a third view, and you can see how the whole front of the lung on the right is being spared by radiation. So she completed treatment. She had no side effects. At 1 month, she had just some mild fatigue. At 4 months, her breathing was stable and her energy came back to normal. And at 4 months, we did a scan, and the nodule had decreased in size by half and had no activity on the PET scan. And this is just an example of the CT after the radiation. You can see the nodule's gone. You just see some kind of haziness there, and that's some minimal scar tissue from the radiation. And this is the PET scan that showed some activity that can happen after SBRT. And we routinely don't do PET scans after SBRT anymore because of that reason. So who can we treat lung SBRT with? Well, we can use this in patients that are frail, that have nodules that in the past we would have been treating a lot normal lung and causing a lot of problems. So this is the nodule in this patient, and we can treat it very safely, limit the amount of radiation to the normal lung, and limit side effects. This is an example of a tumor that's close to the heart. In the past, this would have been very difficult to treat because if we would have treated it, we would have been treating a good portion of the right heart. With these techniques now, the amount of radiation of the heart would be minimal, and this would be a safe treatment. And the third example here, this tumor is close to the center of the chest, and the food pipe sits right here. Well, the food pipe does not like doses of radiation. So in the past, if we treated this aggressively, we would have a lot of problems with the patient would have a lot of problems with swallowing. Over the years, with these techniques, we can treat this tumor, limit the amount of dose to the esophagus, and limit the amount of problems with swallowing in these patients. And then finally, this is just one example again of basically using SBRT and doses of radiation, a lot of sparing of normal lung versus a more crude technique of radiation where all the path of normal tissue where the radiation goes through gets full dose and potential for problems. So in conclusion, advanced radiation techniques such as SBRT and IMRT have allowed us to deliver radiation more precisely, resulting in improved cancer control, which is obviously very important, with less side effects and reduced number of treatments. A lot of times we can treat patients over the course of days and not weeks. So all this definitely plays a role in helping us improve outcomes and quality of life with these patients. And I think that's all I have. So I will stop right now and hand it back over. Thank you.
Thank you for that, Dr. Colonias. We do have one question in the chat. The question is, how does a low-dose lung CT compare to a regular CT scan with contrast of the chest area?
You want to take this, Tom, or you want me to?
I can. You can add. A low dose CT is what's been proven to help detect nodules. Now, when we do these screening CTs, if we find something, sometimes we end up doing a CT with contrast. So the low dose CT does have its limits. With the contrast, you can see the blood vessels better and the lymph nodes better. But in general, for screening, the low dose CT looks at the lung, and we can detect nodules, and that's really the basis of why we're doing the screening.
Okay, I don't see any more questions. Let's see, let me check our chat. Okay, no, I think we're good.
Yeah, I don't see anything in the chat either, Michelle. I think we're ready to wrap it up. Yeah.
Okay.
Well,
Margie, before we wrap it up, I just want to remind tonight's participants that this lecture was recorded, and that it'll take about a week or so to get uploaded to our YouTube playlist. And lastly, if you are interested in making an appointment to see one of our physicians within the Allegheny Health Network Cancer Institute, please call our Hope line at 412-578-4673. I would like to take this moment to thank Dr. Colonias and Dr. Weksler for giving their time this evening. A very interesting lecture tonight. Thank you so much.